Good afternoon, everyone, and I'd like to welcome you all to day 2 of the ASAS Symposium on Axial Spondyloarthritis. We have some exciting topics for discussion today. We have eminent faculty of ASAS Group. Co-chairing with me today this afternoon is Professor Xenophon Baraliokos, and I would like to welcome him on this session. So we all know Professor Baraliokos. His name is synonymous with MR imaging of spondyloarthritis. He's one of the pioneers and has had great contributions in this field. We've had particularly a long journey with him in Middle East with MRI imaging workshops, and we've benefited from his knowledge extensively. Interestingly, he has orthopedic and rheumatology background, makes it a perfect combination. His research interest, as we all know, is focused on the field of spondyloarthritis, especially emphasis on imaging outcomes and treatment. Professor Baraliokos is the current president of ASAS, and he holds membership of several rheumatological societies. So I'd like to welcome Professor Baraliokos to chair this session. Thank you.
Thank you very much, Pavna. It's always a pleasure to see you and work with you. So I'm really happy that we take this up together again. On this second day, I was speaking to Professor Zipper about yesterday's meeting, and he was actually very happy about how things went. So I hope I will, and I'm pretty sure we will continue doing exactly the same thing and having exactly the same outcome today. I remind you, yesterday the meeting was very much focused on the diagnosis, including imaging, since we do know that imaging is not a diagnosis, but a diagnostic tool. We also have heard things about the challenges in unmet needs in AXPA. And we have made this program as such that today we will go go a little bit deeper in the clinic, speak about the clinical aspects and how to measure things, not only the clinics, but also maybe outcomes in terms of treatments. And of course, we will speak about the treatment options we have in this disease. So we have a really very exciting topic today, and I'm very much also looking forward to the presentation of the 2 local cases. I think it's always very nice to see how people think maybe similarly or differently and discuss this with you. And we have really a very good faculty for today, Professor Van Galen, Professor Van der Heid, and Professor van Bosch. I think you all have the program in front of you. I will start the meeting now by introducing Professor Van Galen to you, and thereafter we will go on with the presentations. We have been asked to get the short bios of each speaker. Although we know each other for many years, it's always nice to have that written and not make any mistakes about where people are working and where they have graduated from. So I'm speaking about, again, Floris Van Halen now, who, and I read it out, has graduated from the Faculty of Medicine in the Vrije Universiteit in Amsterdam. So in 2000, and since January 2011, he has been a medical specialist at the Department of Rheumatology at the LUMC. In his clinical work, he's specialized, of course, in spondyloarthritis, and especially in patients, in the treatment of patients. He's the doctor of the responsible for the spondyloarthritis Scott Early clinic space, and he's a chairman also of the scientific committee of the rheumatology department. He's working since 2015. He's also a vice chairman of the special spondyloarthritis work group of the Dutch Society for Rheumatology. I'm also particularly happy because he is a member of the executive committee of ASAS, and we're working very closely together in his new role as a treasurer of ASAS. So it's always a pleasure when Floris is speaking. We always learn new things. And Floris, I'm really happy that we have you with us. Please go on with your talk. We are very much interested to hear what you have to say.
Thank you very much, Xenophon. Is my shared screen okay? You just want to see the slide? Yes, it is. Okay. Well, thank you very much for the invitation. A very interesting subject, clinical aspects of axial spondyloarthritis. I think I have about 6 hours of presentation ready, but I'll have to reduce it to 16 minutes. So, and actually I completely reworked the presentation because I saw the cases that were brought in and I thought, these are experts already, so I have to really step up my game. And so I made a special version of my presentation. It's called the however and also version of the presentation. And just to jump into it, it's a bird's view of certain clinical aspects of axial spondyloarthritis because you're already at the expert level as it is. These are my disclosure. I'm a full-time employee of the LUMC, and as Stefan already mentioned, I'm also involved in ASAS. So this is, I think, a very familiar slide. Two things here. There's a diagnostic delay in axial spondyloarthritis, but also very intriguing to see. It's a German study, if I'm not correct and incorrect. The disease starts before the age of 45, and we really have to use that to focus on the right patients with chronic back pain, because we know that back pain itself is very prevalent, but we want to be efficient in our diagnosis and also referrals. We have to really take that into account. So the fortunate thing is, and this is the first also, most of these studies were done in Europe. But we've recently learned through the PERSPA study that essentially all around the world, if you look at axial SPA patients, the age at onset before the age of 45 is fairly consistent in all parts of the world. So it's really helpful to know that it's a very basic building block for diagnosis. So it's very useful to have confirmation that it's a feature that is shared in all parts of the world. So chronic back pain, of course, is the main symptom of axial SPA patients. Over 3 months is an arbitrary cutoff, but that you have a chronic definition, and it has inflammatory characteristics. But having inflammatory back pain, of course, doesn't mean you have axial SPA all of the time. In fact, if you follow patients with inflammatory back pain, so a pattern of back pain that has inflammatory characteristics, some reports have followed those patients. And for instance, in this example, you can see that about 30% of those patients really did have axial SPA. And of course, you are aware that there are kind of definitions for inflammatory back pain. I always find that a bit difficult to really pinpoint what's an insidious onset. Well, that's something I can, pretty much feel very confident, but improvement with exercise. Some patients are a bit vague about their responses, but still it's a useful tool to look at pattern of the back pain. However, this is an however slide, up to 30% of patients do not report inflammatory characteristics. So that is also possible. And there's another however. If you're working as a rheumatologist, I generally only see referred patients, so either a GP or an orthopedic surgeon has said perhaps someone should look into this in more detail and see if this axial SPA. And as a result, these are results from the SPACE cohort, something we've been working on for the last 12 years, a cohort of patients with chronic back pain who are referred to a rheumatologist. And there you can see that inflammatory back pain or a pattern of inflammatory back pain is also fairly common in patients who do not have axial SPA. Not necessarily doesn't mean that inflammatory back pain is not useful. It simply means that this is likely the reason they were referred to us. So in a rheumatology clinic, you may see an enrichment of patients who have inflammatory characteristics in their back pain, but simply the reason they were referred in the first place. So if you look at peripheral manifestations, I think sure you're all aware that you can have arthritis in patients with axial spondyloarthritis, that it has a somewhat different pattern than, for instance, in patients with rheumatoid arthritis, more large joints, and also importantly, the root joints, so shoulder and hips are more typical of axial SPA, of spondyloarthritis than, for instance, rheumatoid arthritis. And of course, enthesitis, something very useful to look into if you have a patient referred to you, particularly in the Achilles tendon. It's possible to separate that with some certainty from tendinitis, because the Achilles tendon is longer, so the insertion is then more affected than the mid part. And dactylitis, of course, is also a feature we see in spondyloarthritis patients, but it has a differential diagnosis. I think 2 or 3 weeks ago, I saw a patient, or one of the interns saw a patient who had sarcoid arthropathy with beautiful dactylitis. So it's not necessarily that it's SPA, but most of the time it's indeed a patient with a spondyloarthritis. If you look at extra-articular manifestations, of course, you all are aware that patients may suffer from uveitis, psoriasis, inflammatory bowel disease, or a combination thereof. And this is not new, of course, and this is an example of a uveitis patient. It's related to HLA-B27. But also, and this is a personal opinion, in my opinion, uveitis is the most important educational item for axial SPA patients. When we see new axial, if I diagnose a patient with axial SPA, I generally send them to the nurses to really be informed about their disease. And I think the most crucial part is to inform a patient with axial SPA that he or she is at increased risk of uveitis, because it is sometimes a neglected sign. And we saw in the last year's lockdown some very bad examples. I have approximately about 300 axial SPA patients in our clinic. And because of diagnostic and therapeutic delay, because of the lockdown, patients were reluctant to go to the hospital. GPs were difficult to reach. The hospitals were difficult to reach because they said, please stay at home. I had a young lady last year who lost eyesight completely in their first episode of uveitis. So he had symptoms, didn't really go to the, was indeed aware that she had axial SPA and could be a uveitis, but things took too much time. One older patient had lost 60% of eyesight. Unfortunately, that has improved dramatically because he had so much trouble getting to the hospital because of a recurrent uveitis. So uveitis, because symptoms can progress really rapidly, the eye does not have a lot of room to expand in an inflammatory situation, and you could really lose your eyesight in uveitis. So it really needs treatment. In general, psoriasis itself, if patients have skin disease, they show it to their doctors. And inflammatory bowel disease, of course, also has its symptoms, which prompts most patients to seek medical expertise. Also, uveitis is a good way to start with a diagnostic procedure of axial SPA. And this is exemplified in an Irish study where they looked at if patients with a uveitis also had undiagnosed SPA, and that was indeed the case. And what we see in the SPACE cohort, so if patients are referred because they have a uveitis and they have HLA-B27, which is also of course connected, and they have chronic back pain, the likelihood of them having axial SPA is very substantial indeed, unsurprisingly. Then physical examination of the spine, very useful for differential diagnosis also. And we also are aware that over time, patients, of course, with severe ankylosing spondylitis or radiographic axial spondyloarthritis, I should say, have severe or may develop severe limitations in their spinal mobility. However, there is a downside to measuring spinal mobility in individual patients. And 2 examples. This is again in patients with recent onset symptoms. So from the SPACE cohort, patients with limited disease duration. Limitations in spinal mobility do not really help to differentiate patients with axial SPA. So in the upper panel, you see lateral spinal flexion, and the red dots are axial spondyloarthritis, and they're circles. If you're having trouble reading the differences between red and blue, there's possible SPA and no SPA, and you see a general overlap. And that's because patients who do not have axial SPA but also have back pain may also have limitations in their spinal mobility because of pain. And over time, you do see a slight trend going down, meaning that lateral spinal flexion by itself deteriorates or is less prominent over time as well. So that's limited. So you can't say based on unless it's a patient with really advanced disease at diagnosis, limitations in spinal mobility are less useful in making a diagnosis, although I would recommend doing a physical examination because there are other things you can learn from examining the spine. For instance, scoliosis is one thing, and I think last 2 or 3 months ago, I pressed on a particular painful vertebrae, and it was indeed a spinal vertebral fracture. Also, measurement over time, you can see a very dramatic plot here. It's measurements of spinal mobilities over time, and they tend to, and this is a single patients. These are all these spaghetti plots are single patients, and they really are sometimes really going up and down because of symptoms itself. So, as a trend over time, it's very difficult to really say from one visit to another if you see a change in a spinal mobility test that is really consistent over time. Looking at complementary tests, so laboratory testing and imaging, HLA-B27 testing has gone much more available, which is a really useful test because it's a dichotomous outcome, yes or no, HLA-B27. There are some concerns that there are rare variants of HLA-B27 that do not seem to confer risk of axial SPA. Notable are HLA-B27-06, which is more prevalent in East Asia, and 09, which is a rare variant that occurs in Sardinia. And if you look, I tried to do a meta-analysis, and it does seem that 2706 indeed is not a risk factor for axial SPA itself. However, these are rare variants. I've had a discussion with we reviewed typing results in The Hague, which is the western part of the Netherlands, which has a fairly diverse community, and these variants we were able to detect them in a very small number of patients. So please be aware that depending on your situation where you are, I don't think 2709 is ever going to be prevalent in your community unless you work in Sardinia. Could be different if you work in East Asia, but I think in other parts of the world, an HLA-B27 test is really mostly detected risk variants for axial spondyloarthritis. I think Robert is going to say something about, keeping you in time, between differences between non-radiographic and radiographic axial SPA, similar extra-articular manifestations, and also peripheral manifestations. What I would like to finish with is there's also a lot of interest in gender differences, slightly different patterns, sometimes more extra-articular manifestations. Perhaps uveitis a bit more common in males, not really. We looked at it in the space cohort. You do see gender differences, but mainly, I think if you look at the diagnostic strategy, we've looked at multivariable models, separating males between females, and what's important, and essentially you see that what's important in diagnosing males is also important in diagnosing in females. So HLA-B27 testing, additional imaging. So in general, yes, there are at a group level differences, but there's also individual differences, which could also be very substantial. And we think that it's not needed to have a separate diagnostic strategies for men and women. So these are conclusions. Of course, chronic back pain is very useful. It's very important manifestations. You have peripheral manifestation and extramusculoskeletal manifestations. It's really pattern recognition. So there's very little doubt that you will be needing physicians, well-trained physicians, to make a diagnosis. We can't rely on computer algorithms to diagnose axial SPA so far. And that's what I wanted to talk to you today.
Thank you very much for that very interesting talk. I think we're leaving the questions after the next session.
Yes.
Is that right? Yeah. So we move on to the next topic, and it gives me a great pleasure to welcome and introduce Professor Desiree van der Heijden. She needs very little introduction. As we all know, that she's had extensive contributions in the field of rheumatology. Professor van der Heijden is a professor of rheumatology at Leiden University Medical Center in Netherlands. Her major research interest is in the methodology of outcomes assessments and its application in clinical research. Specific areas of interest are radiographic scoring methods in rheumatoid, psoriatic, and spondyloarthritis, as well as scoring of MRI in spondyloarthritis, which is a very hot topic now. She was the chairperson of ASAS for a very long period of time, from 1995 to 2012, and has published more than 950 papers in the international literature, as well as book chapters in leading rheumatology textbooks. She's Associate of Annals of Rheumatic Diseases. We are really excited to listen to her next talk on what and how to measure in axial spondyloarthritis. Thank you very much.
Well, thank you very much for that very kind introduction. And indeed, I like to discuss the outcome parameters in axial SPA, what and how to measure. And as already also my colleague Floris van Galen mentioned, we were instructed that it should be an advanced course. So it's not really presenting all the various measures. Of course, I will mention a few of them, but I also will try to give you some more and more recent information. These are my disclosures. I think relevant for the talk today is that I'm the developer of the ASAS, but be assured that there's no copyright on it, and I also do not receive royalties. This is a very old saying from Werner Wright, that clinicians may all too easily spend years writing doing well in the note of a patient who has become progressively crippled before their eyes. And I really hope that this is not happening anymore, but I'm not completely sure. And if we monitor a patient in daily practice, we ask usually, how are you doing? So it's a kind of global assessment, but it doesn't give a number. And do you awake during the night? How is your pain? Is it mainly during the night, or where is your pain located? Do you have morning stiffness? Can you do your work? Which treatment do you use? And we perform a physical examination. But it's important to really quantify this information. And that's important also to really know if you are treating a patient well. One of the overarching principles in the ASAS management recommendations is that the primary goal of treating a patient with axial spondyloarthritis is to maximize health-related quality of life. But you do that by the control of symptoms and inflammation, prevention of progressive structural damage, preservation or normalization of function, and social participation. So to know if you are really reaching your goal, you need to measure this. And there's also a real recommendation that's about disease monitoring. And disease monitoring of patients with axial SpA should include patient-reported outcomes, clinical findings, laboratory tests, and imaging, and all with appropriate instruments and relevant to the clinical presentation. And I think that's also important. You do not measure everything in every patient, but only when it's relevant for a patient. And the frequency of monitoring should be decided on an individual basis, and that depends on the symptoms, the severity, and the treatment. But there are also other recommendations, like the treat to target in spondyloarthritis. And here it's stated that the treatment target should be clinical remission, or inactive disease as we call it in AXIAL SPA, of the musculoskeletal, but also the extra-articular manifestations. And again, the treatment target should be individualized based on the current clinical manifestation of the disease. If the patient is suffering mainly from psoriasis or arthritis, then that should be the main focus of your target, of course. And also, the recommendations of the treat to target principle is that inactive disease is defined as the absence of clinical and laboratory evidence of significant disease activity. And I like to stress this because it doesn't mean that you need to get rid of everything. So if there is still a little bit of complaint, but it's okay for the patient, then that's fine. And this is really to prevent overtreatment. And also, minimal disease activity or low disease activity may be an alternative treatment target. And that depends on what you discuss with your patient and the situation of your patient. What is an acceptable target for a patient? And then disease activity should be measured on the basis of clinical signs and symptoms and acute phase reactants. And I think that's also an important aspect. And in AXIAL SPA, it's mentioned that the ASAS is the preferred measure. If we think about the relationship between inflammation that's leading to loss of function immediately, it's also leading to structural damage in the long term, and structural damage is also leading to loss of function. And we can measure these different aspects of the triangle in different ways. So the inflammation you can think of measures as BASDAI or ASAS or MRI. Loss of function, the BASFI or the ASAS Health Index, spinal mobility, and structural damage, the AMSAS. We focus on inflammation because that's your target, and when you really reduce the inflammation, then you expect that you also reduce the consequences of the inflammation. But MRI is not useful to really measure it frequently. You cannot measure it every time that the patient is coming to the clinic. So as such, it's not useful for this goal. There was an investigation by Pedro Machado if health-related quality of life is indeed the consequence of all the other aspects, and that's the case. So you have the level of disease activity has a direct effect on health-related quality of life, but also on the other aspects. And the combination of spinal inflammation, especially in early disease, and structural damage in later disease, together with these activity, leads to reduced spinal mobility. That spinal mobility together with disease activity leads to reduced physical function and altogether to reduced health-related quality of life. So it's disease activity that's the main focus. You are aware of the BASDAI, which has 6 questions on patient-reported outcomes, including fatigue, but also the back pain, the peripheral joints and enthesis, and morning stiffness. The ASAS is a measure which has 4 different patient-reported outcomes, and also the CRP is in one version, or the ESR. In principle, we always use the ASAS with the CRP, and only if that's not available, then you use the ASAS with the ESR. And you do not use them, you do not mix them. So it's not one visit with CRP, another one with the ESR. If we compare the BASDAI and the ASAS, you see that there are 3 patient-reported outcomes which are identical. And then in the BASDAI, in addition, you have fatigue, tenderness of the enthesis, and the severity of morning stiffness. While in the ASAS, the unique measure is the patient global assessment of disease activity and the CRP. And what's also different is that in the BUSDI there's an equal weighting of the 5 domains. You first make one domain of morning stiffness and then you have 5 domains. While in the ASAS there is a different weighting of the 5 domains. And that's determined by statistical methods to give the best balance of this information of these 5 domains. Also, the cutoffs for inactive disease, low disease activity, high disease activity, and very high disease activity with the ASAS have been determined by external anchors. While for the BUSDI, we use some cutoffs, but they are not validated against external anchors. They are just chosen by us rheumatologists. That's also the case for change scores. There's a clinically important improvement of at least 1.1 and a major improvement of at least 2. And more recently, there was also a definition of clinical important worsening. The ASAS can be assessed easily in an app, and this can also be done for the BUSDI. So there's the ASAS app, which can be used on all types of smartphones and tablets. And here you can very easily calculate the measures and also get an interpretation of what the level means. People say frequently, okay, but in clinical practice, I may not have the CRP available, so that may be an issue to calculate the ASAS. Well, it's not required to have the CRP measurement exactly on the same day. So sometimes you can even take the measurement from a previous visit, assuming that there was no change in treatment, of course, and it was not too long ago. But you can also set up a clinic where the patient first comes and gets a CRP measurement prior to the consultation, and when you see the patient, you have the CRP available. In some countries, you can also use the GP, and the GP can already order a CRP before the patient is coming to the clinic. And if you really can't get it in time for the clinic, you can always call the patient and discuss the ASAS and the consequences after the visit. Comparing the ASAS and the BUSDI, both have good psychometric properties. The validated status and improvement scores are available for ASAS, but not for BUSDI. The BUSDI is completely a reflection of the patient perspective, but also the ASAS has a good reflection of the patient perspective. While the relationship of the BUSDI with the physician global of disease activity is really poor for BUSDI and is significantly better for the ASAS, the BUSDI may be freely available in clinical practice, but not for research, while the ASAS is always freely available. The BUSDI is easier to use because you don't have a CRP. An important aspect from the ASAS that there is a proven relationship with structural damage. So you know that if you reduce the ASAS, and the lower it is, the more impact it has, the lower the progression in structural damage. But if you only take BUSDI into account, there was no relation with structural damage. Again, if you take the BUSDI plus CRP into account, then you also can show that there is a relationship with structural damage. ASAS has a proven clear relationship with work. It has not been proven for BUSDI, but that's what you expect. There's with the health index, they are both related. There is no redundancy in the ASAS. That was the way it was constructed. But in BUSDI, there's a lot of redundancy. If you take the back pain question from the BUSDI, you have more than 80% of the information which you can also get from the entire BUSDI. And I mentioned the other aspects already before. We have a core outcome set, and a core outcome set means that is the minimum that should be measured and reported in all clinical trials, in audits of practice or other forms of research for a specific condition. The chosen outcomes need to be relevant, both to the health service users and also others who are involved in making decisions and choices about healthcare. It does not mean that in a certain trial that's limited to the core set. You can always add other outcomes, but the core outcome set is a minimum and is mandatory so that you know that all the important measures are assessed in each trial and that also there's a good comparison possible between various trials. The core outcome set of domains was already developed in 1995. There was a small addition in 1999, and that's the one that we still use. And per domain, there was also a definition of the instruments included. So for function, it's a BuzzFeed. For pain, it's a question on the last week pain in the spine at night. And the second question, last pain of the spine in general due to the disease. These should not be combined. So I frequently see the mistake that then thereafter people start averaging these domains, these two questions, but that's not the purpose. You are two separate questions. Spinal mobility, there are various measures mentioned. Patient global assessment, peripheral joints, the number of swollen joints, and a validated enthesitis score. X-ray of the spine, the lateral lumbar and lateral cervical spine, but only in special trials. The duration of morning stiffness, CRP or ESR, and the fatigue question of the BAS-DIE. But as this is already quite an old core set, there is an update ongoing. The old ASAS OMER core set was for ankylosing spondylitis, and now this is being updated to become the ASAS OMER core set for axial spondyloarthritis, so including all patients with axial SpA, irrespective if they have radiographic sacroiliitis. The scope of the new core outcome set is axial SpA, with or without peripheral manifestations, with or without extramusculoskeletal manifestations, but the pure peripheral SpA is not covered by this core outcome set. It's for all patients who have axial SpA, and it's meant to be included in all types of studies, the pharmacological and non-pharmacological interventions, except for surgery. We think there you really need other outcome measures. But for the pharmacological interventions, you can think of two different types: the symptom-modifying treatments like NSAIDs, and also physical therapy belongs to this, and the disease-modifying treatments such as biological therapy. And there are two different core outcome sets for this under development. It starts with a systematic literature review, qualitative studies to know what patients and physicians find important, and a Delphi round. And then in the end, we have a lot of patients and a lot of SpA experts included, and that brought us to have the core outcome set of domains. These are these domains. It's an updated core outcome set that's not been published yet, but hopefully that will be done soon. And there are first mandatory domains. And you have the mandatory domains for all trials. The domains that are covered is disease activity, pain, morning stiffness and fatigue, physical functioning, overall functioning and health, and adverse events including that. The latter domain is mandatory for all OMERACT core domain outcome sets. Then we have additional mandatory domains if you want to investigate if a drug is a disease-modifying drug. Then you also need to collect information on extramusculoskeletal manifestations, peripheral manifestations, and structural damage. Then we also mention important but optional domains like spinal mobility, sleep, work, and employment. And you have seen spinal mobility. Floris van Gaalen has nicely illustrated that this is really a difficult measure to use. So that's also why it's not one of the mandatory domains. For several of these domains, the instruments will probably remain the same, but there may also be some changes. One of the instruments that could be included is the ASAS Health Index, and this is an index assessing health in patients with axial spondyloarthritis. It contains 17 items, which is measuring function, disability, and health. And this is a concept which came from the ICF, the International Classification of Functioning, Disability, and Health. ICF is an important concept which is applicable to all different diseases, and the ASAS Health Index is the first instrument that's really based on that concept. It can be used in clinical trials or in clinical routine as a new composite index that captures the relevant information on the health status of patients with axial spondyloarthritis. So you can see it as a kind of health-related quality of life measure. Here are the 10 questions, and on the next slide another 7 questions. So there are more physical questions, like, for example, I have problems running. Like question 9, it's more emotional. I'm finding it hard to make contact with people. So in total, there are 17 questions, and there's a range from 0, which is completely normal, to 17, which is the worst health index that you can have. It's available on the ASAS website, and it's available in many different languages. So it's likely that you can find your language here, and if not, and you're interested in validating it, you can contact the ASAS people. I mentioned for the extra domains that are mandatory for disease-modifying drugs, you need to measure the extra-articular manifestations, which is acute anterior uveitis, psoriasis, and IBD. And it does not need to be assessed with, for example, a skin measure or an IBD with an endoscopy, but we have developed easy measures, and these are all published. They are also available in the slide set from ASAS. And for example, like uveitis, so a diagnosis has never been made, was known at the president's visit, or is made since the last visit. And if you have a diagnosis, then you measure some simple things about the treatment and the episodes. And that's also available for inflammatory bowel disease, for psoriasis, and also for dactylitis. Most people will not have it, so you can easily say no, and then you don't need to assess. And if a patient has it, then you complete where the dactylitis is located. Also for enthesitis, for clinical trials, it may be needed, if it's the focus of your outcome, that you really measure it within MASAS. But for clinical practice and also for larger epidemiological studies, it may be sufficient to just assess it like it is on the screen. And the same for peripheral joint involvement. So I started off showing recommendations that are available for monitoring, both in clinical practice and in research. In clinical practice, it should be tailored to the clinical picture of the patient, but consider the axial, the peripheral musculoskeletal, and also the extramusculoskeletal manifestations. ASAS has advantages in comparison to the BASDAI, and therefore it's a recommended measure. The update of the core set of domains is already performed, and the selection of the instruments is ongoing. So I hope that this will be done early next year, and that also will be published, and you can see the new updated core set. And I like to end with another quote from Peter Drucker. You can't manage what you can't measure. Sorry, you can't manage what you can't measure, and if you can't measure it, you can't improve it. And that's in the end what we want to achieve with our patients. Thank you.
Thank you very much, Desiree. I think it brings it absolutely to the point, to what you said also during the presentation about not only measuring and understanding, but also improving things, which is what we really try very hard within ASAS. Now I'm happy to give the word to Professor Philip van den Bosch, who will speak about treatment options and how to decide. As a reminder, Professor van den Bosch is working at the Ghent University in Belgium. He graduated there in 1991. He became board certified in rheumatology in 1996 and also received a PhD degree in 2003 on the topic of TNF blockade in patients with spondyloarthritis. He is now the head of clinic and associate professor of rheumatology in the Department of Rheumatology in Ghent University. And as you may all know, this department is extremely successful and very well known for both the clinical and for the basic research in spondyloarthritis, including a large history and also improvements in the life of patients by checking, for example, the relationship between spondyloarthritis and gut. And it's also a regular center of excellence since 2006. Professor van den Bosch is also member of the executive committee. He has been the treasurer of the ASAS from 2012 to 2020. And he's also a member of other groups such as GRAPPA. And Philip, we are very much looking forward to your talk.
Thank you, Xenophon. Thank you also to the organizers and to ASAS for inviting me for a lecture on the treatment options in spondyloarthritis, more specifically in this symposium in axial spondyloarthritis. So here you can see my disclosures, which are probably the usual ones that I have spoken for company-sponsored events, and that, of course, if you want to do research, both basic, clinical, translational, you sometimes have to go into collaboration with companies in order to perform that type of research. And so what I would like to start with is, as Desiree also showed a number of slides on the ASAS EULAR recommendations for the management of axial spondyloarthritis, I think this is a very important one, which we have to keep in mind, even if we focus now on axial SPA. And it is that the treatment of a patient and the treatment choices that we make should be individualized with regard to the current signs and symptoms of the disease and with regard to other manifestations than the actual manifestations. So we also took into account peripheral arthritis, extra musculoskeletal manifestations, and comorbidities. And that is actually inherited or inherent, baked into the spondyloarthritis concept, I would say. You see here the classification criteria. I will not go into detail, but you see all the different components of the classification criteria, all the different aspects of spondyloarthritis. And it reminds us, as Floris said in the introductory lecture, that indeed these patients predominantly will complain if they have axial SPA of axial disease, but that there may be a peripheral component which we should measure. There may be dactylitis and enthesitis, and there could be indeed extra articular manifestations. And all of these may impact the choices we make when we start treating the patients. Now, in my idea, the treatment of axial SPA actually consists of three pillars. And the first pillar, I would say, is the non-pharmacological treatment. The second one is the non-steroidal anti-inflammatory drug treatment, often forgotten, which I think is a pity. And then the third pillar is a large pillar, of course, which consists of targeted therapies, both biological therapies, where we have most of the experience, but also now growing evidence for targeted synthetic therapies. And while you are still awake, and while we know that indeed the attention is mostly highest at the start of the presentation, I just talked about the three pillars that are important. I will immediately mention the pillars that are completely non-important when we look at axial SPA, and that is the classical conventional synthetic DMARDs, which you see here, have no efficacy on axial manifestations. This may, of course, be different when you look at peripheral manifestations or perhaps when you look at certain extra-articular manifestations. And the second thing, which probably is unacceptable with regard to side effects, is the, I would say, inefficacy of corticosteroids with regard to the treatment of ankylosing spondylitis. You see here there is some response to be seen, but if you go into 20 milligram of prednisolone, which I would still consider as somehow a bit acceptable, you don't see a lot of difference for ASAS 40 response with regard to placebo. And you have to go really high, which is probably a non-sustainable option. So 3 pillars: non-pharmacological NSAIDs, targeted or biological synthetic DMARDs, and there are a number of things which we actually don't use in axial spondyloarthritis. And so here are the grid, I would say, of the management recommendations for axial spondyloarthritis. They were published in 2016. They will also, like you heard about the outcome measurements core set in the previous lecture, they will be updated probably in the next years. And so there may be small difference, but I think the overall principles will still stand. And what is very important, if you look at the phase 1, I think it's the parts at the right and at the extreme left. So this is the non-pharmacological treatment education. And actually, if you compare, for example, to EULAR or GRAPPA recommendations for psoriatic arthritis, that is not in there. It's a major distinguishing between, I would say, the axial SPA manifestations and axial SPA management recommendations and the other recommendations where we put a key focus on education, non-pharmacological treatment. And to me, that's a simple 3-step process. You have to accept and you have to really teach patients that axial SPA is a chronic disease for which I would say currently there is no cure. And by cure, I would say we mean you give a treatment temporarily, you stop it and the disease is gone. But the good news is that it is a disease that probably needs chronic treatment, but that can be controlled by chronic treatments. But that's a crucial step. I think education, non-pharmacological treatment, and of course physiotherapy, which I will not go into detail, but that's the first step. And it needs to be repeated, I think, at multiple time points when you make decisions about treatment options and treatment choices. So let me go back to the phase 1, and now we're looking in the middle. So we have the patient is now educated. So that's the point where you start pharmacological treatment, and that would evidently be non-steroidal anti-inflammatory drugs. It is in the recommendations, recommendation number 5, stating that patients suffering from pain and stiffness should use an NSAID. They should use it at the maximum tolerated dose. And of course, as a physician, but you know that you take risks and benefits also into account. And I will come back to that in a minute. If patients respond well, continuous use can be advocated. And we know that these drugs work. You see these very old data on the left, which was actually Bernard Amour's data, showing that the application of NSAIDs in ankylosing spondylitis patients led to a very good efficacy, whereas in standard mechanical back pain, that was not the case. And we also know this to the right from clinical trials, placebo-controlled clinical trials with good response when you are put on a drug, on an NSAID at full dose versus not really impressive response when you are on placebo. And I will show you a little bit more in detail. This is the Ettore-Coxip study, for example. And now we're not looking at small improvements, which are usually reported, but this is 6 weeks of treatments, ASAS partial remission, which is a very stringent measure. And you can see the 2 Ettore-Coxip doses actually reaching about 15 to 20% of patients getting into ASAS partial remission. So that's a good response, and we should never forget that this should indeed always be our starting point. This is from a recent review of the Cochrane database, where you can see multiple NSAIDs, and it conveys the same message, I would say. On the top of the slide, you see traditional NSAIDs Below, you see the COX-2 selective NSAIDs. And of course, regarding short-term efficacy, NSAIDs are favored above, let's say, the placebo group. And if you look at short-term safety within these trials, then you can see that overall there is, of course, safety issues, but the lines are crossing the one axis here over here. So meaning that essentially we can deal with this and it's not that much of a major problem. I remind you that, as Floris mentioned, axial spondyloarthritis is a disease which is diagnosed before the age of 45. And probably that is one of the reasons why we don't see that much of a problem with NSAID use compared to, for example, use of NSAIDs in older stages diseases like rheumatoid arthritis or in osteoarthritis, where cardiovascular aspects have to be taken much more into account. Now, this is short-term safety, of course, but we also have some data with regard to long-term, and this is just one study where actually you can see in a large cohort of ankylosing spondylitis patients, you see the risk factors for cardiovascular disease, which are the known risk factors, of course, but you actually see that on top of statin use, which seems to be somewhat protective, NSAID use also did not convey at least a higher cardiovascular risk. And of course, there's lots to be saying about this type of analysis, but to me, it looks like giving this to the right patients with an inflammatory disease may have beneficial effects in the long term. And the question is, how does this translate into clinical practice, in daily life practice? And this is data from the DESIRE cohort. This is a publication by Anna Molto. And at first sight, it looks rather good, I would say. You can see here that at inclusion in this real-life cohort, more than 90% of patients are taking NSAIDs. And over time, you see 3-year data here. Actually, 75% of patients are still taking NSAIDs. However, in daily life, the somewhat disappointing aspect of this is that if you look at the median ASAS NSAID score, which tells you how much patients are taking, and I remind you, it needs to be 100% in order to have a patient that is taking the maximum tolerated dose on a daily basis. And it's closer to 50, even a little bit less. After 3 years, you see that the median actually goes down in a large degree to almost intake on a very occasional basis. So this is, of course, real life. Patients not always like to take it, but I think here again is a role for education in order to explain to our patients that indeed we have to treat them with NSAIDs as a starting point. And if we do that, and now I ask you to look at the left side, this is from the INFAS study. This is a study in early axial spondyloarthritis patients that were not yet treated with NSAIDs. And then the patients were randomized to either receive full dose of an NSAID, which was naproxen, or they were receiving the naproxen plus infliximab. And of course, if you look to the right, and we're looking here at ASAS partial remission, so again, a very stringent outcome. The anti-TNF plus the NSAIDs led in 2/3 of the patients to ASAS partial remission after half of a year of treatment. But on the other hand, only the NSAIDs given at the correct dose in early disease over time, we're looking here again, as I mentioned, at 6 months, leads to 1 in 3 patients reporting a very good and a sustained improvement as defined by the ASAS partial remission criteria. So don't forget your basics. Start NSAIDs, give it in a good way, and we know how to tackle some of the side effects, I would say. Now, of course, there are definitely patients where that doesn't work, but I would like to remind you again that all too often when we see in our university hospitals, we see patients being referred. And, well, you can discuss, of course, if the diagnosis is correct, but that's not the point I want to make here. But patients are coming in, they are classified, diagnosed, whatever. And one of the criteria by which they are classified is, oh, the patient had a good response to NSAID. And then they are, 2 weeks later, they are put on an anti-TNF because they don't respond anymore. Again, I would like to stress that NSAIDs, usually when they work, they have a pretty consistent efficacy. And I would be very cautious with patients that respond for 2-3 days to an NSAID, then do not respond anymore. if you put them on an anti-TNF, I would be a little bit cautious. But suppose we're now at the stage where indeed we did this the correct way, we have to escalate treatment, and suppose the patient is a relatively solitary axial spondyloarthritis patient, because of course, if the peripheral manifestations come in, that may bring you to the point where you would like to use conventional synthetic DMARDs. But in case of solely treatment with solely the manifestations of axial spondyloarthritis, I think we would say that in case the physician thinks it's a good idea, we would start a biological DMARD, which at the current stage is in the treatment or in the management guidelines still an anti-TNF therapy. But of course, this may change over time with growing evidence and with emerging evidence from potentially head-to-head studies that will come out in the near future. I want to stress that in the next 2-3 slides, you will see data put together on a slide, and that, of course, this is not a head-to-head. We don't have head-to-heads in Axial SPA at this moment. So, but this is just to give you an idea, not to say that one drug is better than the other. I've focused here on very stringent outcomes. So you will see for the anti-TNFs, 24 weeks of treatment in ankylosing spondylitis. To the left, you'll see data on partial remission, because that was the old outcome set, I would say. To the right, you see the newest outcome measurements, such as ASAS inactive disease, which would be my preferred outcome, and which was already discussed at large by Desiree in the previous presentation. But you can see very little placebo response if you go to stringent outcome measures, and a significant proportion of patients reaches actually a state of what I would call remission. TNF inhibitors, ankylosing spondylitis. Do we have data for the non-TNF targeted therapies? Yes, we have. You can see here to the left data with an IL-17 inhibitor. This is ASAS partial remission, and it goes within the same ballpark. In the middle, you can see data for another IL-17 inhibitor, ixekizumab, which has comparable data. And you can see from a biological DMARD inadequate responder trial with a JAK inhibitor, upadacitinib, also data within the same range. And as Desiree mentioned, we can use certainly in certain patients, depending on the profile of the patient, other measures. We don't have to go to ASDAS inactive disease every time. We can go for low disease activity. And if you do that, for example, in the same 2 studies with an IL-17 or with the JAK inhibitor, you can reach significant improvements in these patients. If you go one step earlier, so now we're not talking about ankylosing spondylitis, but I'm pooling here the data that we have on non-radiographic axial spondyloarthritis. And again, you have to be a little bit cautious in comparing this. To the left side, you see data with regard to ASDAS inactive disease. And overall, these studies with non-radiographic disease may have some issues, at least some studies may have some issues with higher placebo responses, but then usually you also see higher efficacy when you look at stringent outcomes, and the delta between the active drug and the placebo is usually within the same reach, which is about 20%. So fairly comparable, I would say, to the data we have in ankylosing spondylitis. And actually the only study where in one trial the patients were pooled together with non-radiographic disease and radiographic disease were the studies with certolizumab, which actually showed really overlaying results for almost all the outcome parameters. You can also appreciate here that there seems to be, and again, I remind you, this is not a head-to-head comparison, but there seems to be no difference with regard to response between anti-TNF agents and agents targeting other cytokines, such as IL-17 inhibitors. And that leads us to the last part of this grid, of course, which I will not go very much into detail, which is the part where if you are failing one of these drugs, what you should do. And actually, since we don't have head-to-head comparisons, probably we have to say that at that point, you have to go to the whole system again, look at patients, educate them, try to figure out what is the reason for their pain. And as Floris mentioned in the earlier introduction, you push on the spine, you find a very tender vertebral structure well, you should check probably if that's not a fracture instead of just switching from one drug to another. But if you've done that, and if you failed really some of these treatments, then you can go to another one within the same class or within another class. So how to decide? That's my final question in the last 5 to 7 minutes, I would say. How to decide? Well, I think you have to take something in mind. First of all, we have so far, I would say, no magic bullets. There is no clear-cut test which can tell you if this is positive, you should use that drug. If that is positive, you should use that drug. Biomarkers are interesting, but they are at this moment still in the research agenda, should be confirmed. And so I think it will be quite a long time before we will have something where we can say, well, in this case, you simply do that. Of course, there are a number of what I would call no-brainers, but I think that number is small. And with the no-brainers, we're usually looking at the extra musculoskeletal manifestations. And if you go to targeted therapies and you look at the two major groups we have available now, the anti-TNF agents and the anti-IL-17 agents, well, it seems like a no-brainer that if the skin with psoriasis is involved very heavily, you go to an IL-17 agent. If the gut is involved very heavily with Crohn's disease that is active, that is really ulcerative, then of course you go to an anti-TNF agent. But again, I would like to stress that probably those are the two extremes of the spectrum, maybe only covering 5% to 10% of the total group of axial SpA. So that leaves us with quite a large gray zone, I would say. And this is very old data. It goes back 10 years now. This is data from a PhD thesis from Nathan Vastensager, where actually he looked in patients with ankylosing spondylitis and tried to figure out in a sort of cholesterol and cardiovascular disease grid what type of patients would be at risk or what type of patients would respond very well. And what you can see here, you can actually draw two profiles. You can draw patient one profile, which is a young patient, which is a patient that has the right genetic background, which is a patient that's inflammatory with an elevated CRP, and which is a patient with a rather low BAS-Phi in his ankylosing spondylitis situation, testifying to some extent that there probably is not yet a lot of structural damage. Now, if you add an anti-TNF therapy to that patient, you see he has more than 50% of chance of reaching partial remission. And that, of course, translates in very good numbers needed to treat. You need to treat only a few of these patients in order to achieve these major responses. If you took the other way around, you take an older patient with ankylosing spondylitis, but for some reason the patient doesn't have the B27, and of course I'm drawing the extremes here now. The patient is non-inflammatory but has a lot of structural damage as witnessed, for example, by the BAS-Phi. That's a patient where you may need to treat a lot of patients in order to get one patient into partial remission, because simply the drug you're giving, which is tackling inflammation, is not working on a lot of structural damage that is already present because of previous inflammation. So this is old data, as I mentioned, but I think it still stands in our clinical reasoning when we try to figure out what to give to patients. And it becomes more fancy, of course, if we look at newer studies. And here you see an example from a phase 3 study with an anti-TNF agent with non-radiographic disease. In this case, it was adalimumab. You see that on the left side, if you take patients that either have an MRI, clear-cut inflammation, or have an elevated CRP, that there you see a response. This is an ASAS 40 response compared to placebo. If you have none of these, so no MRI, no elevated CRP, then the response actually becomes very doubtful. So this gives you an idea which drug I should choose. So probably in that type of patients, a strong anti-inflammatory agent with, for example, an anti-TNF agent doesn't seem to make a lot of sense. And of course, the more of these factors you have, it's not on this slide, but if you have MRI and CRP, actually the numbers even diverge even more. So I think this shows the same as the previous slide, but it's a bit more fancy. It incorporates MRI. And yesterday you learned a lot about MRI. So I think this is how you try to use it in your decisions. And it holds true in daily practice. This is data from Anna Molto. Anamoto and from the Desir cohort, which I mentioned before. And you see here ASAS 40 responses on the left side in patients that have MRI sacroiliitis, on the right side in patients that have no MRI sacroiliitis. So we're only taking out one of the parameters, and yet you see a clear separation, better response. So that is something to take home with you. Could we potentially make a distinction or make a choice based on radiographic damage? These are my last slides. I think not. What you see in the middle is a study. So these are studies, actually the 3 studies with drugs, certolizumab, golimumab, secukinumab, that have data in ankylosing spondylitis with regard to radiographic damage, modified Stoke ankylosing spondylitis spinal score, over a period of 4 years. If you look in the middle, it looks a bit like the old adagium, which we knew from the infliximab studies, which we knew from the adalimumab and etanercept studies, when comparing patients treated with an anti-TNF for 2 years, for example, and comparing them to historical cohorts, like, for example, the OASIS cohort, we could see no difference in these patients with regard to structural progression, leading to the initial thought that anti-TNF agents might not have an impact on structural damage. And that's more or less what you see over here with the golimumab study. When you look at the IL-17 agent here, you see that the numbers are lower. This is 2 to 4 years, 0 to 2, 2 to 4, and 0 to 4 years. But again, if you now look at another example of a TNF blocking agent, you see very similar points there. And I just checked before this presentation. The GO-RAY study actually was performed in 2005, while the other 2 studies were, at least in our center, submitted to the ethics committee in 2010. So I think this has to do with the changing landscape in the clinical picture and not as much with the efficacy of the drug. So unfortunately, and I have to say that with a little bit of caution, because we will have some data on a head-to-head trial comparing an IL-17 inhibitor to an anti-TNF inhibitor. But for now, we don't have very strong data to suggest that one is better than the other with regard to structural damage. And over here, you see data from the Swiss clinical quality management cohort, which was published about 2 years ago, where all the parameters were looked at with regard to structural or inhibition of radiographic progression, and where you can see on the top that TNF use prior to the radiographic interval actually seemed to be, to some extent, a protective factor with regard to structural damage. And here you see another important thing, I would say, which is in the same cohorts, a relation between the response to that treatment. And you can see clearly that if you get the disease well controlled, and here you see the cutoff with ASAS inactive disease, less than 1.3, actually this leads to a very good disease control, which is somewhat less when you allow for higher hurdles. So again, I refer to the previous presentation. I think measuring the disease is important. I think we should strive to get the best possible improvement in our patients. And by doing that, I think if the patient responds well, we will have this impact on structural damage if you look in the long term. And I would like to end here, and this is actually, again, a slide from the slide deck of the ASAS EULAR management recommendations for AXIAL SPA, published a couple of years ago. But I think it summarizes potentially the whole ASAS course that you have been going through over the last 2 days now. It starts with a correct diagnosis. You have to make a diagnosis of AXIAL SPA. I am convinced that the only person who can do that are trained rheumatologists, just as yourselves. And you take into account, in order to make that diagnosis, the different components that are in the criteria that you know from clinical practice, and you try to figure out, as Floris put it, the gestalt of SPA. Then you have to look at some factors that could actually predict that what you are seeing in these patients is driven by inflammation. So you're looking at CRP, which is a very good marker. It's not elevated in all patients, but at least it is a good marker regarding response to treatment. Or you can look alternatively to other objective measures of inflammation, such as MRI, that is positive. Or if you don't have available MRI, clear-cut radiographic sacroiliitis as a third option. To me, I would also say other objective measures of inflammation could be the presence of extra-articular, extramusculoskeletal manifestations, a patient with repetitive uveitis attacks, a patient with active Crohn's disease, a patient with severe skin psoriasis. These are all objective signs of inflammation, I would say. And if we look at that, then we are going to measure patients and we're going to say, well, do you have active disease? Taking all these things into account, and as mentioned, with a preference for a more objective parameter that has also shown that it is associated with structural damage, which is the ASAS, and you take an ASAS cutoff above a certain value, which is high disease activity or higher. And then if you failed the standard steps that I went through, which is you go to education, you go to non-pharmacological treatments, you have given the patient a good trial with NSAID, then comes the point where you start with a biological or a targeted synthetic DMARD potentially in the future. And so far, I think the choices are to some extent yours. Of course, you take into account experience, and we have 10, 15, 20 years of experience for some of us with TNF blocking agents, but that will flatten out, I think, over time, and we will have to learn how to use this in the future. So with that, I'm ending my presentation, and I think we will then go to the cases or to question and answers. I will give the word back to our chair.
Thank you very much, Professor Bosch, for that very interesting talk. Next is the Q&A session. So I think what we can do is possibly divide the Q&A session into our virtual questions, and also we have audience here. So should we start with questions from the audience here first, and then I think Xenophon, you can take questions online. Is that okay? Yeah.
Yes, sure. Go on, because you have the overview on site, and then I will read out the questions that are in the chat.
Thank you.
Thank you very much for all the speakers and to you, Bahafna. I got actually two questions, if that's possible. The first one is actually for Dr. Van Den. Actually, no, it's for Vanda. The question is about the outcome measures, and seems in ankylosing spondylitis we fell in the trap of having a very subjective outcome measures. And I know what we've spoken about, the clinical examination could be problematic, but at the same time, all the outcome measures are based on patient self-assessments and pain and morning stiffness. And actually, two questions about morning stiffness. And in the best case scenario with ASDAS is you have the CRP, which could be actually not raised in about 40% of the patients. So I think we have an issue, and I think that's need to be looked at, is the physician assessments is not looked at all here. Even in terms of the tender joints count, it's the patient's self-assessment of tender or tender's emphasis. We are sort of far from the rheumatology, the DAS28, which is very subjective, very easy to use, or the BILAG or SLEDAI, which are very difficult to use, but very, let's say, complex as well. So where are you going down this route? Because if you're going to stick with the same, I know there's some work as you presented to us, but we're going to stick with the same concept of the patient self-assessment, we're still having the same issue. And I personally see patients improving significantly on biologics, and when we test their BASDAI, they're still as high as 6 and 7, and say, why on earth are you giving me these high scores?
Yes, thank you for this challenging question. Indeed, we are relying mostly on patient-reported outcomes, and I think we would love to have more objective outcomes. And as such, the CRP is very useful, but as you say, in a large proportion of the patient, it's not elevated, so then it's not useful. We have the other objective measure is MRI, so this is useful to know the level of activity, but still you cannot use it for monitoring the disease because you cannot repeat the MRI constantly. So we are a bit stuck. And you mentioned the tender joint count. Well, it's not really self-assessed because it has also been tested. If you ask a patient to indicate on a mannequin the number of tender joints, and you ask a physician to assess the tender joints, that is only in agreement when there are no tender joints. As soon as there are tender joints, there's a huge discrepancy between what the physician assessed and what the patient assessed. Another important aspect is the number of swollen joints, but also here you have the same issue that it's only in about 25% of the patients that have swollen joints. So in the cases where you have subjective information available, that's very helpful. And in the others, I don't really see that in the near future we will have better subjective outcomes. And you mentioned outcome measures in SLE. They are objective, but they really have also quite a number of problems, and they do not work in clinical trials. While the patient-reported outcomes in ankylosing spondylitis, they really work well in clinical trials. So although it may not give the full picture, it still gives you a good impression of what's ongoing. But you always, as a treating physician, you have to keep in mind that it needs the level of complaints need to fit with what you see in the patient.
Okay,
May I
thank you very
add
much.
something?
Yeah.
I think Philip wanted to add something here.
Yes, I would like to support the view of Desiree in this. And I think the way to solve this is actually what is in the management recommendations, which is the point where you say you start with a diagnosis by the rheumatologist. That's where you filter out some other issues that may drive up the BASDAI. And the other thing is actually whether you start a biological treatment, which I think is the high hurdle. It's not a big problem if you start with an NSAID, where again, you need also the rheumatologist's opinion. So I'm not completely, I do understand the point of the question where we say, well, there is a problem with the physician, but the physician is incorporated in that it's in fact he or she who decides based on the total picture whether we start treatment or escalate treatment.
Yes, and if I may add, what of the benefits? So the one of the questions was if I still have a high BASDAI or ASAS for that matter, and I'm still happy with the response. I think one of the things I particularly like about the ASAS is it's able to, it provides you, and I think you see the right bottom corner in the ASAS I'm using, is it allows you to assess improvement, which I find personally even, well, I have to really choose, even more important than the total level of disease. If I have someone who's on really high disease activity and it drops 2 points in an ASDAS, that's a really impressive response. And so that's something I really note down. So, but and the other part is that that you should always be critical of if you have a patient-reported outcome. So you say, do I also personally feel that it does reflect disease activity or inflammatory disease activity?
Thank you very much.
I think you have another question. Okay.
My second question is to Van den Bosch. In terms of the NSAID, in inflammatory arthritis generally, apart from ankylosing spondylitis, we drifted away from NSAIDs, and seems we still stuck in the last century in terms of the AS, in terms of we still have to use the NSAIDs for patients. My concern is that, are we preventing structural damage or not? And I cannot really, have you got an explanation why the cardiovascular risk is lower in COX-2 inhibitors among AS than what we know that they're actually bad otherwise?
Okay, so 2 points. I'll start with the cardiovascular. Of course, big studies are lacking. My guess would be that if you go with other diseases, like I mentioned, rheumatoid, which are typically older patients, take more steroids, or in osteoarthritis patients, you have more problems with regard to cardiovascular comorbidity at the start. In the younger patient population with AXPA, which I would situate when they are getting diagnosed somewhere between 20 and 40, probably that negative aspect of cardiovascular disease doesn't play that much. And potentially the bad news of having chronic inflammation, which is not controlled, is worse for the heart than what you would expect in patients that are not treated with NSAID. So I think there's sort of protective role there to be very cautious. of NSAIDs with regard to taking away inflammation. That's the first. The other question you had was about, do we have not improved yet? Well, yeah, it is what it is, I guess. In rheumatoid arthritis, we have conventional synthetic DMARDs. We've drifted away there from NSAIDs. But as I've shown you, we have nothing with regard to short-term symptomatic treatment with regard to steroids. Conventional DMARDs do not work. And there is the high hurdle of having an anti-TNF being very costly. So I think this might change over time when treatments become in another way available, but that is for the future, I would say. And so far, I would think that the risk-benefit ratio of an NSAID is still pretty good.
So, any more questions from the audience here? Yes, Beena. We've got one more question from the audience. Dr. Beena here.
Hi. I just want to ask you, as we're all talking about that it's very subjective bias that we're using nowadays, is there any role of ultrasound, in particularly patients who have enthesitis, to incorporate into the present, along with the patient-reported outcomes, to improve the situation here?
Okay, I will address this question, but I also would like to give some comment on the previous question. That's why I had raised my hand. The question was also NSAIDs and radiographic progression. Well, there are data exactly on NSAIDs that there is an effect on MSAS progression. So there we have, in fact, more direct information than from the biologicals. So it's not a specific reason for not prescribing NSAIDs that you would do some harm on the syndesmophyte formation. That was still the other question. Now about the ultrasound. That may be, but also ultrasound is not as easy in axial SPA as it is. I think today I saw an editorial viewpoint published in Annals of Rheumatic Diseases of the use of ultrasound for enthesitis in axial SPA and PSA. That was about the OMORACT definitions. And there it's clear that if you have good definitions, then you can assess the large entheses in patients. But still there are many questions around also that you also see those same abnormalities in persons who do not have enthesitis or do not even have axial SPA. So it may in the future turn out that can be an additional tool, but I think currently we do not know how to use it.
Thank you.
So I think in the best interest of time, we should see some of the online questions as well. But I think before that, maybe a quick answer. We always talk about how long. So NSAIDs, if a patient is responding well to NSAIDs, how long would you continue? And when would you like to withdraw NSAIDs?
Well, I think the management guidelines are rather clear on that. I think if the patient responds well, you keep on with the treatment and you assess risk benefits. So of course, if there's a side effect, if there's a problem, that's another situation. But suppose the patient is doing well, you keep on with the treatment. I think all of us probably in daily practice will try to taper at some point and we'll see where it gets you. So what I personally do, I start full dose. If the response is good, I at least keep it on for some time, and then I try to lower the dose and gradually taper it. If that works, you can potentially get to a situation where you have intermittent treatment of patients, where you treat them for a couple of weeks, a couple of months, then you stop. Or you can get to a situation, that's at least my experience in daily practice, where you can get to taking an NSAID every other day, where you actually lower the ASAS NSAID index, and where you still keep the disease well controlled. And of course, I think every clinic visit should start with the risks and the benefits. So at some point, there may be a problem with NSAIDs, and that's the point, of course, where you start escalating to other treatments. But I'm a little bit opposed to a situation where you say, well, I just nowadays, and you see it more and more, I fear, I use the NSAIDs, I give it for 2 weeks, it responds well, and then I escalate to the TNF blocking agent. I don't think that's what we should do. I think we should be cautious. We should probably see where we can get with an NSAID, but of course, if needed, and there are some factors like a constantly elevated CRP that doesn't go down, other manifestations which bring you to escalate the treatment. So the duration, yeah, it's up to every clinical situation. It's hard to put guidelines on it, I think.
Thank you. So over to you, Zerafon.
Yeah, well, the time is almost over, but I still think there is one or two important questions. This also goes to you, Philip, because of course you've touched on a topic which is something that we all have to deal with. This is treatment. I would like to know your opinion, and I just read out the question. Is there any preferred medication to be used in the era of COVID? Obviously from what you just mentioned, we are still speaking about a patient with spondyloarthritis. There are obviously currently 3 to 4 options: NSAIDs, TNF blockers, IL-17 blockers, and JAK inhibitors. So what's your opinion on that?
Well, I'm probably too simplistic on this, but I think the drugs we're currently using, we don't see major problems. I know at the start of the COVID pandemic, there was some issue, probably not based on very good data from France, that NSAIDs would be a problem, but the recent publication actually learned us that that is not truly the case. I don't think we've seen, and I would have to look at the EULAR guidelines which were presented, that there are major problems with the drugs we are using, but potentially a little bit of caution with regard to JAK inhibitors when you just get infected. So I guess it's a question of timing. If you would know I'm infected today with COVID, probably we would stop the treatments if we would have to give them today for a very short time, but we don't know that. So the point is, you only know it when you have the disease, and then potentially you go to the more severe cytokine storm like COVID disease, and then I think potentially even the treatments we give may have a benefit. So I'm not all that worried personally.
Yeah. There's 2 other questions. The one I will respond myself. It's easy. Is it possible that inflammatory back pain would be induced by biologics such as TNF blocker as a paradoxical reaction? I say no. To this, at least, there is no reason to have such a rationale. Although, of course, back pain can always happen, and also patients who have good response to a TNF blocker or other biologics, if they also have the genetic changes in the lower back, they may also present with back pain, which is not affected by the drug, which may also mimic inflammatory back pain. And there's one other question, the last one, in AS patients who are doing well for years on NSAIDs, but then they didn't really come back to follow up, and all of a sudden they do show up, and there is MRI lesions, inflammatory lesions, without clinical complaints. Do you think that it would be a reason to change the switch to a biologic? So no symptoms, constantly on NSAIDs, but MRI is positive.
So you're asking me?
I'm asking everyone.
Yeah, I would say that for me, the MRI is not the predominant thing. It's if the patient really has no pain at all, I would refrain from treating an MRI, but I'm not the best placed to say that, I would guess.
Yeah, Desiree, please.
Yeah, I fully agree. First of all, I would not know that there are lesions on the MRI, because I would not make an MRI if the patient has no complaints. So this is fully theoretical for me. And if that would be the case, indeed, we are not used to treat images. And it doesn't say where the MRI was from, but we know that there is a lot of MRI abnormalities also in, for example, the spine, which are not due to the disease. So I would be very reluctant to treat based on MRI lesions.
Floris?
Yes, it brings me back. I was also trained as an internal medicine specialist, and I'm so happy to be working in rheumatology because patients have symptoms they need treatment for. And in internal medicine, I was always treating hypertension, and patients were not that interested in improving their hypertension or diabetes or osteoporosis. So I was always very happy that patients in rheumatology have symptoms and they would like to get treatment for that. So that's my basic knowledge.
But let's assume now the patient or the colleague who's asking has had a case like that on an NSAID doing well, and I don't know, the GP did an MRI, there is some inflammation on the MRI. I would also not treat the image. Our recommendation is clearly treat the symptoms. Okay, we will go on. If any other questions come up, we will see them, monitor them, and if there's time at the end, we will answer them later. I'm very happy to go to the even more interactive part of this day today, which is the two local cases. I'm very happy to see Humaira here, Humaira Bacha, who we all know very well. She's a consultant rheumatology in Dubai. She has over 2 decades of experience as a rheumatologist, practicing also in the US, Singapore, and Dubai. And she's a co-founder and board member of both the Emirates Arthritis Foundation and the Emirates Society of Rheumatology. So, Humaira, we're very much looking forward to listening to your case.
Thank you so much, Xenophon. Nice to be here with all of you. I'm in New York, actually, and it's raining here. So my case is a very short case, actually. I have only one slide, and it's sort of to discuss this kind of things which we've been discussing before, the challenges we have ahead of us in assessment of patients with back pain, and also, you know, sometimes in sort of a disparity between their symptoms and BASDAI scores, and then a disparity between BASDAI scores and MRI findings. So this is a 48-year-old man who saw me about 2 or 3 months ago. He had complaints of pain in his upper back. It was on and off for a year, but got very severe over the previous 2 months, and increasingly difficult to sleep for him. He felt worse when he was lying down at night or sitting long, and he had morning stiffness for 30 minutes. He was better with activity. He said he had no lower back pain. He had recently shifted from India to Dubai in January of 2021. And in India, he had some blood work, including a negative HLA-B27. His CRP at that time was normal. His ESR was normal. So when he saw me, despite this very severe back pain, and difficulty sleeping, his BASDAI score came up only to 2.7, and below I have written his breakdown, where it's mainly for back pain, which was the problem, and everything else he scored almost 0, and his CRP was 4 here. We had a modified Schober's test. His lumbar spinal mobility wasn't very low, very affected. So I gave him some etoricoxib 90 milligrams. And because I was not very sure, there was some disparity between how he described the symptoms, unable to sleep, and his BASDAI scores. His CRP looked okay. We got an X-ray and MRI of his sacroiliac joints. And I saw him back in follow-up with these results of the X-ray and MRI in 2 weeks, at which time he said, oh, I felt miraculously better with etoricoxib. Even after 2 or 3 doses, I felt 100% pain went away. His BASDAI was 0.7. His ASDAS was 1.1. I didn't write it down here. And I have the X-ray and MRI for review.
Xenophon, here's Torsten. Do you want me to show the MRI scan?
Yes, please do that. Yes.
So here we go. So we have an MRI of the SI joints in 2 planes and also of the lumbar spine. Here is first the T1 weighted, and perhaps in parallel the stir sequence. So you see that there is much structural changes. So there is some backfill here. There's fatty lesions. We have one transitional vertebra, which has also a little bit inflammation in the stir. But we have also inflammation in the sacroiliac joint on the right side currently. We have all structural lesions besides ankylosis on the SI joint. And also when you look at the spine, we have some classical images, so active corner lesions in the stir sequence, and a lot of fatty corner lesions also.
So just for us, for understanding, these MRIs are from the very beginning? Are they, let's say, very recent after the NSAIDs? I mean, nobody.
Yeah. So,
would
sorry,
expect-
his initial symptoms were thoracic pain, and then he did shift to lower back pain. And these MRIs were got after he just started on NSAIDs, a few days after starting NSAIDs, when he was actually feeling better.
Yeah. So does anyone want to comment? Otherwise, I can start with a comment.
Go ahead, Jennifer.
My take on that is that obviously even NSAIDs have a very great effect, as Philip said before. And obviously it means that we do have the issue of maybe deciding now on whether or not to escalate the treatment just because of the image, because the clinical part is absolutely very well or is very well treated or very well managed. I don't know whether or not you have the freedom or you have the luxury to decide on treatments which are more expensive than, let's say, toricoxib for this patient. But to me, I wouldn't escalate the treatment. I would leave it as it is. Any other opinions? Floris.
Yes, I was well. What was your what was the question behind the case? Because if you review the case, so I started taking notes. I thought the presentation was very atypical for actual SPA. Patient had no clear SPA features other than perhaps a response to NSAIDs. And so I was rather surprised to see the images, because that was very suggestive of actual SPA. But so that's surprising. And it reminded me of, we once did a report, and I asked, because we have a project called the SPACE project, which is spondyloarthritis caught early. And at a certain point, you see also a lot of patients without actual SPA. So I asked to the researchers, is it possible to exclude actual SPA just by doing an interview and do a physical examination? Because oftentimes I hardly ever see any SPA features. It's seldom, but the answer is no. If a patient's been referred, so I clearly remember this case of a young adult who had said no to everything. It was fine, and then it turns out he was H-labitin positive, had a high CRP, and had ankylosing spondylitis. So they're really surprising images. Yes.
I wanted to interrupt here. I mean, I was just wondering why you say there's no SPA history, because he did have very inflammatory sounding back pain.
Oh, okay, good. Well, okay, good, fine.
Right. So, it's only not really fitting finding here is the age. So I would have expected that someone with such advanced imaging changes would have been bothered by the symptoms much earlier. No, I don't remember said that he or she, the patient had started with symptoms longer ago. But sometimes patients just don't really think that much, especially if they respond so well to an NSAID, they just take it and then they stay at home.
So our question, I think, which was also raised with the previous questions, is also, okay, so we have often patients who are treated with NSAIDs off and on, and then they come back, they're doing quite okay. Someone gets an MRI. The MRI shows a lot of inflammatory changes. Are we concerned about progressive structural damage? I mean, if patients because, we're saying that if they're well treated or well controlled on the NSAID, we don't have to escalate treatment. But with such inflammatory changes, are we concerned? I mean, I'm just talking about, suppose this man came back about 6 to 12 months. Clearly, he's been having symptoms for some time, even though he complains of it only now. So are we concerned about ongoing structural damage with this amount of inflammatory changes?
Esira, you wanted to say something?
Yeah, I also found the presentation of the case not very typical, as Floris indicated. But for me, the images were reassuring, because I thought this patient has had much longer symptoms than he is remembering now, probably. So, and then it fits much better in the picture of axial SPA. Again, when this patient is reacting this way to etoricoxib 90 milligrams once daily, I would keep him on the NSAID and give it in a continuous dose. And then you could, after a while, let's say 1 year, you could repeat and see what's happening on the MRI, and also check after a while if there are syndesmophytes progression. And you could also already look now. And if he has a normal CRP, then I really don't see a reason to change.
If I may just comment or ask a question here. I had a similar case yesterday. I think we're talking about clinical scenarios where you have patient whose symptoms do not necessarily correlate with the disease activity, or you may have patients who respond to initial treatment, but their inflammatory markers remain persistently high, or you have MRI changes that we've seen. So the clinical question is, do we still treat them? For instance, in rheumatoid, you see changes very quickly. You put them on a 4-week course of steroids, you can see significant improvement in their inflammation, both objectively as well as inflammatory markers. But in spondyloarthritis, for instance, how long will it take for these MRI lesions to settle or resolve? So we can't keep scanning them every so often. So how long does it take for these inflammatory lesions to settle, both in terms of inflammatory markers as well as MRI changes?
So from my experience as a radiologist, so bone marrow edema is quite persistent. After a fracture, it's over 6 months, and we see it in our trials. It gets less over months, not weeks or days. So it's quite persistent change.
Well, the issue here is twofold, I think. First of all, if you see someone, that's my opinion and my experience, if you see someone who is now inflammatory only, let's say you have an early diagnosis, yes, inflammation may persist, as you said, Øystein. Our fear is here that this inflammation will turn into that what people have published into fat and then to new bone formation. In that particular patient, it doesn't change much because fat is there already. So here, I think the wise decision is anyway keep the NSAIDs. The biggest problem we have no data on that, is what happens to these patients who are well controlled with an NSAID clinically. CRP may be also now normal after some time, but we haven't done much about the inflammatory activity by NSAIDs, because these lesions most probably, if you don't treat them early enough with a biologic, obviously they will turn into fat and then will progress. I think it's a little bit of an emotional topic and also an economical topic on whether or not we would go over from an NSAID to a biologic, and therefore I think it is wise to stick to these recommendations. Also, and again, maybe this is a little bit too bold here what I say, but it is as it is. Also because 1 and 2 syndesmophytes at the very end won't change anything, right? So if you give an NSAID and the patient progresses, and then you see a progression of 2 syndesmophytes, so what? I mean, the patient doesn't really have a huge disadvantage. If the symptoms do progress, then obviously there is a clinical reason for escalation of treatment. That's how I would see the situation as it stands now.
Yeah, and if I can add, it's indeed a slow progressing disease in most patients. So you have time to repeat a radiograph after, for example, 2 years and see if there is syndesmophyte formation. And in the meantime, you can see what's happening on the MRI, and as it takes quite a while before that normalizes that inflammation, you can take that time. And I think that's also different with regard to rheumatoid arthritis. And there there's in the time frame a much closer relationship between the inflammation, the swelling of the joints, and the new erosions in that same joint. That's over a much shorter time period.
But we need to go on. We started 3 minutes later. This is now 3 minutes over the time, but there's still one question that I can answer very fast. In real life, in which case would you ask for an MRI? Well, obviously, the patient has new symptoms. So if the patient is doing well on treatment, we will not recommend a check by an MRI. If symptoms change, obviously towards the worse, then we would do an MRI to see if that's inflammatory reasons or if this is other reasons than that, like degenerative and so on, and check for this kind of things.
But we also see some other scenario as well, Xenophon, sorry to interrupt. Sometimes patients develop, let's say, a thoracic pain, and when you repeat MRI scan, you actually see some new lesions appearing in sacroiliac joints, and while they're on treatment, and they may not necessarily have low back pain or buttock pain at all. So do you actually change their medication at that time? I mean, how does MRI help us in sort of deciding or changing or switching the medication?
I wouldn't do that. I wouldn't change the treatment in that particular case, which I believe anyway is relatively rare, but still may happen. This means the patient comes with back pain in the thoracic spine, and then for whatever reason you also do the sacroiliac joints. There is inflammation there, which has not been there before. I wouldn't very much change the treatment because the symptoms are elsewhere. Yeah, and the question is then, of course, why is there symptoms in the thoracic spine? For any reasons, we also know that these patients who have, and this was also shown by Desiree in the study by Pedro Machado, there might be also other issues that we have to solve for pain, for example, for disactivity and physical function. These things interrelate. It might also be a myofascial issue that we don't really rely on inflammation. Therefore, I would really look at it not only in a very narrow way, but I would really check for, let's say, long-standing disease. Patients may have issues with the muscles, may have issues with hyperkyphosis. All these things need to be taken into account. Yeah.
Thank you. I think in the best interest of time, we should proceed to the next case.
Yes. I am also very happy to introduce the second speaker and the second presenter, which is Dr. Ahmed Al-Zayat. He's a consultant rheumatologist at the University Hospital Sharjah at the United Arab Emirates. His prior experience includes the position of consultant rheumatology in Bradford, UK, and he also has been lead of the rheumatology department there. He is a recognized international speaker for the use of ultrasound, so I think we may also have the chance to get a response on the ultrasound question we had before in diagnosing rheumatic diseases, and he has been very active in different international congresses, both for EULAR, but also for the BSR. And we are happy to listen to this case.
Thank you, Xenophon, very much for the presentation, introducing me, and to the ASAS panel, and to Bhavna and the ERA, and for all of you attending today. If I may add a comment from our ultrasound experience, usually in rheumatoid, if you find somebody with active synovitis, although they think they are in remission, we like to escalate the treatment because we know that it would cause joint damage as per some of the trials. I think what we lack is clinical evidence here, in my opinion, and all still based on sort of experience base. But let's present my case. So this is half between us and you here, because my patient is half Arab, half German, where her father is Arab and her mom is German. And she was in Germany, and she was about 50 plus years in Germany when she went to see a rheumatologist about her few years of back pain. And they've done an MRI images, which I don't have access to, the old images, and they've told her she might have, she has or had an ankylosing spondylitis, and she is HLA-B27 negative, no family history, no psoriasis, and they gave her eterocoxib and seems to have sorted her symptoms, and she was doing for a couple of years. So when she did come to see me, she came with a flare of her pains for a couple of months, increase in the back pain, mainly around the thoracic area, and some sacroiliac joint symptoms. She did have a reasonable modified Schwarber's test. BASDA is really high, as the CRP is again raised. So I did an MRI of her spine, and there are a few changes that might tell us there's some axial spondyloarthritis, but she has lots of bone marrow edema, as you will show us in the pictures in the T5. So the radiologist's question was, was there a neoplasm there or fracture? So we did a PET CT. There was definitely no neoplasm, no cancers, and the DEXA was mainly within osteopenia. So I did a bit of, I gave her a shot of zoledronic acid actually, and then we got the approval for IL-17 inhibitor, and then she did really have a significant improvement after that with a very, very impressive drop in her markers, including the BASDAI and the ASDAS, and she was sort of in remission. Actually, her modified Tropo's test has improved by 2 centimeters as well. So here come to the discussion. What did she have? Did she have a fracture in her spine? Is that just a severe big corner lesion that join each other? What's going in her spine? Is that actually an ankylosing spondylitis or not?
Okay, I can show you the images. Here we go. First, we have some fairly unremarkable X-rays of the SI joints, of the cervical spine, of the thoracic spine, and also of the lumbar spine. Not really much to see here. We have also images from the total spine in MRI. Here we see 2 areas of bone marrow edema, T5 and T7. If we compare it to the T1 weighted image, we have fairly low signal here, and we also see, when you enlarge it a little bit, we also see that the vertebrae are not quite in shape. So I would say this is a osteoporotic fracture. And then we have also images of the SI joint, unfortunately only stir images in 3 planes. Here we see also a bit bone marrow edema on the right SI joint, but at least from the stir image, no structural lesions. I would argue from the radiologist's point of view that she has a quite dysmorphic joint with the iliosacral complex, which might cause some mechanical stress here, and it's not very suspicious of AXIAL. And what we also see here downwards is probably more degeneration than inflammation of the lumbar spine.
So that corner lesion in the lumbar spine that we could see also on the the sagittal plan, is that a plane? Is that why? How did you make it as a degenerative, not inflammatory? If you go back to the other view, the whole spine view, if you go down, there's some another corner lesion in the lumbar spine, the one shown the front, the other view, yeah. How do you make this is degenerative, not inflammatory as well? Because my radiologist put in the report that suggestive features of spondyloarthritis with corner lesions and extra.
Yeah, so I would say we often see those corner-related bone marrow edema in degenerative disease. We also see that the disc is not so normal. So this is a normal disc with really bright T2 signal. Here we have a little bit lower T2 signal. So we have some degeneration going on here. And I would say this one corner lesion does not constitute the diagnosis of AXIAL in an MRI image. So I would be very cautious to overjudge or overcall this one lesion.
I may disagree with that because I think the disc looks pretty okay. It doesn't look very degenerate. And we do have bone marrow edema lesions in the thoracic spine. So could it not be a continuum of the spectrum?
So the disc is not okay. This is a normal disc. This is not a normal disc. And as I said, perhaps there might be one corner lesion. I would not say that this is AXIAL because you have one tiny bit of bone marrow edema in a vertebral corner.
This is exactly the opposite.
Can you show us the lesion further up? The upper lesion, So the one is, I would say, I would not even call it a lesion in the middle one, so the second from the top. But this I wouldn't really pay much attention. But do we have a T1 image of this spine?
Sure. And here you see that you have an end plate fracture here, and also a little bit irregularities here. You don't see it on the X-ray. The X-ray is, of course, a little bit complicated. If she has osteopenia, I'm fairly sure that this is an osteoporotic fracture.
And can you, how would you rate those very little? I'm just, discussing the case generally. Those very little lesions in the posterior part, which, like this one, which may look like, or the others may look like post-inflammatory lesions, fat lesions.
I would say that this is not a classical SPA image impression. So we have perhaps 1 pixel of increased T1 signal in this image. Would be not enough from my opinion. But if all the clinical aspects of the patient point towards an axial SPA, I cannot argue with you. So
could I add a comment, probably to turn up the table slightly? Around the time I was starting her, before I start her, which I didn't put the information in on the slides for the purpose of the discussion, is actually she developed right knee monoarthritis. And it was pretty inflammatory right knee. That was just around before we started the IL-17. And that's again went into remission. Would that change your impression at this point?
If I could comment, also already based on the MRI findings, in the SPACE cohort, we have young patients, and then we had in all of them an MRI of the spine, and only if you have 5 or more lesions, then it was clear that belonged to axial SPA. And also patients without axial SPA, they could have up to 4 lesions. And that's a young population. And this is a middle-aged woman, and there you can even expect more abnormalities in the spine. So it's the MRI is not supporting the diagnosis. So the diagnosis then should be based on the clinical symptoms only.
Would a CT scan help here? If you were unsure about, or if you're considering fracture as a possibility, would a CT scan of thoracic spine help?
So what the CT can do is to give you a lot of more morphological information. Yeah, so in the X-ray of this patient, we do not see the fracture directly, and we are a little bit unsure from the MRI scan if there is really a loss of height of the vertebra. So in this regard, a CT scan might be useful for differential diagnosis, whereas I personally would not perform a CT because I'm fairly sure that this is a fracture.
Here, my question to the other panel: would you stop her IL-17 in this case?
Can I ask you one question before we go to that one? Remind us, because did I remember correctly? IL-17 did help here, correct?
Yes, but I did 2 things. I gave her a zoledronic acid, and I gave her IL-17. So that's confusing.
Yeah, but the zoledronic acid would not. I mean, first of all, okay, it's a different topic, but it would not help much on the symptoms. Can you remind us how much of an improvement she had?
She has significance. So she probably from the second, from within 4 weeks from starting the IL-17, she went into complete remission. She's so happy.
Did she have psoriasis?
No history of psoriasis, no personal psoriasis. And
That's the thing of the. I believe that's what makes it so interesting and really nice. Then obviously you're right. I mean, you're right in terms of the treatment decision. I would leave it there. I'm not saying we don't care about that, but if the patient is doing well, if the patient is doing, then I wouldn't really doubt much on that. And if the question is, should I continue the treatment? I would continue it.
Cool.
Yeah, and the whole question for me is whether this is a patient. I think the question whether this is an actual SPA patient or a peripheral SPA patient is rather irrelevant. It looks like you had a peripheral SPA because he had a monoarthritis of a large joint of the lower limbs, which was inflammatory in its fluid that you took out of the joint, and it responded well to the IL-17 agents. Apparently your back pain improved as well, but it could have been a fracture, as the radiologists tell us, which would also improve over time gradually. So I think it's a question of nomenclature, which usually doesn't help in clinical practice.
And at the very end, it shows that imaging is not everything.
Absolutely. I think
Well,
what I need
we
to do
still
is...
need you, Torsten. We still need you. No, don't worry.
What I need to do is to find who was the German rheumatologist who've seen her in Germany told her AS. Probably one of you
Yeah,
guys.
hopefully it was not me.
You could also look very carefully at the PET scan. So she got a PET CT.
I think you did that,
I remember, and this is of course also a CT scan. So it would give perhaps from the CT side more information.
We did a CT PET, actually, not CT PET. Yeah. Thank you very much.
Great. I think those were really interesting case scenarios. I think we've come a long way in terms of spondyloarthritis, diagnosis, treatment options, etc. But we still have a long way to go. I think we have this clinical dilemma all the time, despite all the advances that we've had. Thank you very much for this exciting session this afternoon. We can probably take a couple of questions if we have any from the audience. Unless, Xenophon, you have any other questions online?
Well, we are a little bit over the time, but there was one question that at least we can, ask Philip to complete this. Do you think that there is, or have you seen any paradoxical inflammatory bowel disease onset under TNF blockade?
Not truly. I must say, no, not in the way that you see paradoxical psoriasis, which is then usually a different type. I think there may be some patients which have already subclinical gut inflammation that then becomes active, but truly a breaking out of inflammatory bowel disease, I cannot say that I've witnessed that.
Thanks. Otherwise, there are no questions from the chat.
That's great. Thank you very much, and thanks for attending this session. We look forward to have the team again next year. So until then, have a great weekend. Thank you very much.
Thank you, everyone, for attending this meeting, by the way. Thanks for the speakers, and have a nice day. Have a nice weekend.
Thank you. Bye.
Bye-bye.